Welcome to our video on acute leukemias. Let's get started. In this lecture, we'll be discussing acute lymphoblastic leukemia/lymphoma, as well as acute myelogenous leukemia. So with regards to ALL, we'll be discussing the general features, chromosomal abnormalities, classification, clinical presentation, diagnosis, and management. Let's start with general features. Acute lymphoblastic leukemia, abbreviated ALL, is the malignancy of immature lymphoblasts. It's due to a block in an early development of T cells or B cells. Therefore, we can have either pre-T cell ALL or pre-B cell ALL. Pre-B cell ALL is the most common type. Both types of ALL are positive for terminal deoxynucleotidal transferase, or TDT. This enzyme is expressed in immature lymphocytes and is responsible for generating antigen-independent diversity of T and B cell receptors. Only pre-B cell ALL is CD10 positive. There are two chromosomal abnormalities characteristic of ALL. The most common abnormality is a translocation between chromosomes 12 and 21, resulting in the TEL-AML1 fusion gene. Patients with ALL accompanied by this mutation have a better prognosis. The protein product of this fusion gene inhibits the differentiation of lymphoblasts. On the other hand, ALL can be caused by a translocation between chromosomes 9 and 22, which results in the Philadelphia chromosome with the BCR-ABL fusion gene. ALL accompanied by this mutation has a worse prognosis. The BCR-ABL gene codes for a mutated tyrosine kinase and is most commonly implicated in the pathogenesis of chronic myelogenous leukemia, or CML. All right, now let's talk about the classification of ALL. According to the WHO classification, we have B lymphoblastic leukemia with recurrent genetic abnormalities, B lymphoblastic leukemia not otherwise specified, and a precursor T lymphoblastic leukemia/lymphoma. B lymphoblastic leukemia with genetic abnormalities includes those translocations that we just discussed on the previous slide. However, a discussion of other mutations included within this subgroup is beyond the scope of step 2. B lymphoblastic leukemia not otherwise specified means that no specific mutation has been linked to this subtype of ALL. Starting slide 7. All right, now let's talk about the clinical presentation. ALL can present with fatigue due to concomitant anemia. Malignant lymphoblasts fill up the bone marrow space, interfering with normal erythropoiesis. A low-grade fever is a nonspecific constitutional symptom due to a generalized inflammatory state. Interestingly, ALL is associated with Down syndrome. There is an increased bleeding tendency, which is commonly due to thrombocytopenia. Just as we discussed for anemia, malignant lymphoblasts crowd out the bone marrow, impairing normal thrombopoiesis. Hepatosplenomegaly and generalized lymphadenopathy is due to lymphoblastic infiltration in the liver, spleen, and lymph nodes. Additionally, bone pain can occur if there are bone metastases. Central nervous system and testicular metastases commonly occur as well. Finally, pre-T cell ALL commonly metastasizes to the mediastinum, especially in adolescents, and this can cause compression of the trachea, esophagus, or the superior vena cava. Therefore, a child with pre-T cell ALL may develop dyspnea, stridor, dysphagia, or superior vena cava syndrome from the external compression of the respective organs. Starting slide 8. Here we have an image showing a patient with superior vena cava syndrome. Notice all of the dilated veins in the patient's abdomen and thorax region. This is due to a backflow of venous blood in the subclavian and internal jugular veins. Starting slide 9. A diagnosis should be made with the peripheral blood smear, which will show lymphoblasts. We also get a CBC, which will show a lymphocytosis. And finally, a bone marrow biopsy can be obtained, which will show greater than 20% of lymphoblasts. This is in contrast to chronic lymphocytic leukemia, which is characterized by lymphoblasts occupying less than 20% of the marrow space. Starting slide 10. Here's an image of a peripheral blood smear showing immature lymphoblasts. Starting slide 11. The management includes systemic chemotherapy. Additionally, intrathecal chemotherapy is administered to prevent relapse of ALL in the CNS, occupying less than 20% of the marrow space. Starting slide 12. All right, let's try a question. A 4-year-old boy is brought to the physician by his parents due to a swollen red face and arms. The mother first noticed swelling and redness 1 week ago, and these symptoms have progressively worsened. The patient has also felt fatigue for the last 2 months. He has difficulty swallowing solid food. The physical exam shows hepatosplenomegaly, generalized lymphadenopathy, and diffuse petechiae. A peripheral blood smear shows immature lymphocytes. The tissue specimen obtained by the bone marrow aspiration shows positivity for terminal deoxynucleotidal transferase. What is the most likely cell of origin of this patient's condition? All right, this patient is presenting with a swollen red face and arms. This is consistent with a diagnosis of superior vena cava syndrome. He's had difficulty swallowing solid food, which is suggestive of esophageal compression. Additionally, he has fatigue, hepatosplenomegaly, generalized lymphadenopathy, and diffuse petechiae. A blood smear shows immature lymphocytes, and the tissue specimen is positive for TDT. So this is a classic description of acute lymphoblastic leukemia. The question asks us what the cell of origin is of this patient's malignancy. Considering that he has signs of mediastinal infiltration, such as superior vena cava syndrome and esophageal compression, the most likely cell of origin is the T cell. Starting slide 13. All right, now let's move on to discuss acute myelogenous leukemia, or AML. Starting slide 14. With regards to this topic, we'll be discussing the general features, chromosomal abnormalities, classification, clinical presentation, diagnosis, and management. Let's start with general features. Starting slide 15. Acute myelogenous leukemia is a malignancy of immature myeloblasts. It's due to a block in the early development of granulocytes. The risk factors include previous exposure to alkylating chemotherapy or radiation therapy. Both of these types of therapy can induce irreversible changes in the bone marrow stem cells, which increases the risk for AML. Down syndrome is also associated with a specific subtype of AML, namely acute megakaryoblast leukemia. Additionally, chronic myelogenous leukemia can transform into acute myelogenous leukemia, and this process is known as a blast crisis. Finally, myelodysplastic syndrome has a significant risk for transforming into AML. Starting slide 16. Let's discuss the chromosomal abnormalities of a specific AML subtype known as acute promyelocytic leukemia, or APL. APL is caused by a 1517 translocation that creates the PML-RARA fusion gene. This fusion gene results in an abnormal retinoic acid receptor alpha on the surface of promyelocytes. Therefore, there is impaired maturation of promyelocytes. Starting slide 17. According to the WHO classification, there are several types of AML. First, there is AML with recurrent genetic abnormalities. An example of AML within this subgroup is acute promyelocytic leukemia that we just discussed. There's also AML with myelodysplasia-related features without prior history of cytotoxic therapy. Therapy-related AML is the one induced by chemotherapy or radiation therapy. Finally, there is AML not otherwise specified and the myeloid sarcoma. Starting slide 18. All right, let's talk about the clinical presentation of AML. As you can see, the clinical features are not much different from the ones of ALL. AML can present with a fever due to a generalized inflammatory state. It can also be accompanied by dyspnea and fatigue due to anemia, as well as an increased bleeding tendency due to thrombocytopenia. Patients commonly have hepatosplenomegaly, but lymphadenopathy is rare compared to ALL. AML can cause tumor lysis syndrome due to an intense cell turnover. Finally, APL can present with DIC. I'll explain the mechanism behind this concept once we talk about the blood smear findings in APL. Starting slide 19. This is an image showing petechiae of a patient's body, and this is most commonly caused by thrombocytopenia, which can be secondary to AML. Starting slide 20. All right, now let's discuss tumor lysis syndrome in more detail. This is due to the rapid lysis of the leukemia or lymphoma cells either spontaneously or after treatment initiation. Cellular breakdown releases several substances into the bloodstream. The release of potassium results in hyperkalemia and ECG changes. Phosphate release causes sequestration of serum calcium, resulting in hypocalcemia. And hypocalcemia itself can cause tetany and seizures. Precipitation of urinary calcium phosphate crystals can cause an acute kidney injury. Finally, massive release of uric acid can lead to hyperuricemia and can also result in acute kidney injury due to uric acid crystals. Starting slide 21. Tumor lysis syndrome is treated with IV calcium gluconate to counteract the potassium effect on the myocardium and to stabilize the cardiac membranes. Aggressive IV hydration is used to prevent the development of urinary crystals and acute kidney injury. Additionally, allopurinol can be administered to decrease the production of uric acid from the nuclear breakdown of cells. However, this has no effect on the uric acid that is already produced by the time treatment is administered. This is when we can use rasparcase or pegloticase. Rasparcase is a recombinant uricase that converts uric acid to a more water-soluble compound called allantoin, and this is readily excreted by the kidneys without forming crystals or stones. Starting slide 22. Okay, moving on to the diagnosis. The diagnosis of AML includes a peripheral blood smear, which will show myeloblasts and promyelocytes. A peripheral smear can also show Auer-rods if there is acute promyelocytic leukemia. Auer-rods consist of lysosomal enzymes and are myeloperoxidase positive. When the Auer-rods get released from the cells, the enzymes can activate the coagulation cascade, resulting in DIC. A CBC of the patient with AML commonly shows a leukocytosis. Additionally, the bone marrow biopsy confirms AML if myeloblasts occupy more than 20% of the bone marrow space. And again, this is in contrast to CML, which is characterized by myeloblasts occupying less than 20% of the marrow space. Starting slide 23. Here is an image of a peripheral blood smear showing an immature myeloblast with an Auer-rod inside. Starting slide 24. Okay, let's wrap up by discussing the management. The management of AML includes systemic chemotherapy. Selecting a specific medication depends on the patient's comorbidities, age, preferences, and so on. However, acute promyelocytic leukemia has a very specific treatment regimen. It's mostly treated with all-trans-retinoic acid, which is a vitamin A derivative. And this is because all-trans-retinoic acid induces the normal differentiation of promyelocytes. Acute promyelocytic leukemia can also be treated with arsenic trioxide. Starting slide 25. Here is a table that summarizes the key points about ALL and AML. Feel free to pause the video and review the information. All right, with this in mind, let's finish up with the final question. Starting slide 26. A 59-year-old man is brought to the emergency department due to severe palpitations and a tonic-clonic seizure that he experienced 1 hour ago. He was diagnosed with acute myelogenous leukemia 3 weeks ago, and he started induction chemotherapy 2 days ago. He has not urinated for the last day. His vital signs include a temperature of 37 degrees Celsius, a blood pressure of 80/60 millimeters of mercury, a heart rate of 140 beats per minute, and a respiratory rate of 16 breaths per minute. The serum potassium is 6, serum calcium is 7, serum phosphate is 5.5, and the uric acid level is 10. His creatinine is 6 and his blood urea nitrogen is 50. An ECG reveals peaked T waves and prolonged PR intervals. Which of the following is the best next step in the management of this patient? A. IV calcium gluconate, B. IV fluids, C. rasparcase, or D. allopurinol. All right, this patient is presenting with palpitations, likely due to hyperkalemia, seizures, which is likely due to hypocalcemia, and an acute intrarenal kidney injury, likely due to hyperuricemia. He was diagnosed with AML and started induction chemotherapy 2 days ago. Given all of these findings, this patient is most likely experiencing tumor lysis syndrome secondary to treatment initiation. He's also hemodynamically unstable, and the ECG revealed peaked T waves and prolonged PR intervals. Therefore, the first priority in the management of this patient is to stabilize the myocardium against the effects of hyperkalemia, and this can be done with IV calcium gluconate. So the correct answer is option A. Starting slide 27. Recall from this slide that the treatment of tumor lysis syndrome includes IV calcium gluconate. Starting slide 28. Option B, IV fluids, option C, rasparcase, and option D, allopurinol will be used at some point in the management of this patient. However, the best next step for him is to prevent lethal arrhythmias from hyperkalemia, which is why we prioritize IV calcium gluconate over the other options. So B, C, and D are incorrect, and again, the correct answer is option A, IV calcium gluconate. And that concludes this section.